Hi everyone, and welcome to the next session of the Neurology Video Journal Club. I would like to introduce both of the panel today. My name is Rachel Buckley. I'm based at Massachusetts General Hospital and Harvard Medical School in Boston, but I also have an affiliation at the University of Melbourne in Australia. And I'd also like to introduce Dr. Rory Boyle, who is one of the postdocs in my lab. Actually, I'll let Rory introduce himself. If that's
yeah, so I'm a postdoc in Rachel's lab in Massachusetts General Hospital and Harvard Medical School. And I joined from Trinity College Dublin, where I completed my PhD in 2021.
So today, Rory and I are going to be covering a paper that came out very recently. The title of the paper is Differential Effects of APOE and Modifiable Risk Factors on Hippocampal Volume Loss and Memory Decline in Amyloid, Low and High Amyloid Older Adults. This paper was published by a team based in Australia. First author is Dr. Emily Rosenich, and the final author is Dr. Yanying Lim, both based at Monash University in Australia. And I just wanted to give sort of a broad overview of sort of the context behind some of the components in the paper and sort of situate it before we get Rory to walk through some of the findings, and then we'll discuss and give our thoughts. So the paper itself is a really fascinating take on thinking about modifiable risk factors, particularly in those older adults who do not yet show cognitive impairment, so are not diagnosed with a dementia or even a mild cognitive impairment. And what they were interested in was taking a well-validated and well-used risk factor score for modifiable risk factors and seeing to what extent it can inform on somebody's likely progression or likely decline over time, both either in brain atrophy or in memory. What they use in this particular paper is a score called the CADE, and the CADE stands for Cardiovascular Risk Factors, Aging and Incidence of Dementia. And the CADE score, just to give everyone sort of a background on the score, it's very similar to other risk factor scores that might be out there. Some people may also be familiar with things like the Framingham risk score or the Q risk score. There's a few different scores out there. And the CADE was developed from observational studies early on, but coming out in very much from a perspective of how can we understand modifiable risk factors in how they can inform risk for future progression to dementia. And so the CADE risk score is currently used in a few clinical trials. One of the biggest ones in particular is the FINGER trial, one of the non-pharmacological interventions. But this score has been validated not only in observational cohorts and clinical trials, but also across multiple different types of cohorts, multi-ethnic cohorts in particular. And it's been used not only in Europe, but also in the United States. It's based on a combination of different risk factors put together to create a composite score. So these factors are involving things like body mass index or obesity, diabetes status, physical activity, smoking, educational attainment. And so different factors are involved with the composite, which Rory will talk about a little bit more. But the important component to the CADE, which we'll touch upon a little bit more later in the discussion, is that the CADE is supposed to encompass the midlife risk factors and how that might inform later risk for progression to the dementia. So it's really interested in how your modifiable risk factors, how your lifestyle is in the midlife, and how that might inform later on in the life course. So with that, I will hand over to Rory now to sort of touch upon the general components of the introduction of the study and the findings, so that we can then discuss some other points. Thanks, Rory.
Okay, so yeah, so the authors here set out to try and investigate I suppose, the usefulness of the CAID for informing us about dementia risk and future management of dementia risk reduction strategies. So as Rachel touched on, a large component of the CAID involves modifiable risk factors. So there's a need to understand how these modifiable risk factors may interact with fixed factors like age and APOE4 status, and interact with these factors on amyloid burden to increase risk for progression. So we need to understand how these factors do indeed contribute to dementia risk. So the aims that the authors set out to investigate was to look at the relationships over 10 years. So they have incredible longitudinal data between this risk score and markers of dementia in cognitively normal older adults, both high and low, with both high and low amyloid burdens. So the markers of dementia progression that they were specifically interested in were hippocampal atrophy and episodic memory change. And they also wanted to look at the relationship between only the modifiable risk factors, so using a composite score from the CAID that only encompasses the modifiable risk factors, and their relationship over time with these markers of progression as well. And then it's a sort of post hoc or exploratory analysis. They wanted to understand or look at the specific relationships between individual risk factors and these markers of progression within a specific amyloid negative, cognitively normal older adult subset of the data. So as I previously mentioned, they had a really nice data set from the Australian Imaging Biomarkers and Lifestyle Study, or ABLE. They had, I think, 592 older adults with a mean age of about 70 years old. And this included 395 amyloid negative older adults and 197 amyloid positive. So in terms of their data, they had PET amyloid imaging. So they had a few different PET tracers. So they used a centiloid scale to sort of go across these different tracers. And then they had an episodic memory composite measure, and they used adjusted hippocampal volume to assess hippocampal atrophy over time. So they also, the main data point they're really interested in was the CAID risk score. So if we just show this now from their table, I think table 1. So the version that they used in the study, it includes age, sex, APOE4 carrier status, education, hypertension, BMI, hypercholesterolemia, and a measure of physical activity. So there's different cutoffs within each of these categories, and you're assigned a score for each category, and a total higher score equates to a higher risk of future dementia incidence. So if you see here on the right-hand side of the table with the underneath CAID-MR, you can see the modifiable risk factors. So this only includes education, hypertension, BMI, hypercholesterolemia, and physical activity. So there's a total score between 0 and 10, whereas the full composite has 0 to 18. So the main difference, the only difference between the two scores, the modifiable score and the total score, is that you drop age and APOE as well as sex from the modifiable score. So there are some different versions used, I think, Rachel.
Yeah.
A couple where maybe sex isn't included or APOE isn't included, but this is the version used here. And again, like Rachel mentioned earlier, it is worth noting that the CAID was originally developed on a midlife cohort. So while the mean age of the current study was 70 years old at baseline, you can see that would have meant that everyone in this cohort was assigned a maximum risk based on age for dementia, future dementia incidence. So things like that are just worth keeping in mind as we go along here. So I'll just stop sharing that. So using different longitudinal analyses, the authors found that, first of all, what you would expect to find, there was higher CAID scores and higher CAID MR or modifiable risk scores in amyloid positive adults versus amyloid negative. But interesting, what was really of interest was that there was an association or an interaction on hippocampal atrophy whereby there was a higher a higher CADE risk score was associated with greater atrophy in amyloid positive older adults. So, however, when you looked at the modifiable risk factor score, there was no association or no impact of the CADE MR score on hippocampal atrophy. So that really suggests, I suppose, as we all know already, that age and E4 status are very important in terms of hippocampal atrophy. And beyond these two fixed factors, along with sex, additional modifiable risk factors don't appear to add any more, or explain any more variance in hippocampal atrophy. And for episodic memory, there is another association or interaction whereby higher CADE scores were associated with worse or faster or worse memory decline, but these rates of decline were similar in the amyloid positive and negative older adults. However, the CADE MR score, so again, without age, sex, and E4 status, this only had an impact on cognitive decline in the amyloid negative individuals, where there was an association with faster decline. So there's a couple of interesting findings there. And then in terms of the exploratory analysis within the amyloid negative, cognitively normal older adults, the authors found across all the different specific risk factors or modifiable risk factors, only BMI or body mass index was associated with future episodic memory decline. So these are sort of pretty interesting findings. I suppose one couple of like key takeaways might be that they really drive home the notion that risk reduction strategies need to be sort of targeted before the presence of significant amyloid accumulation. So, I mean, this isn't really too groundbreaking, but risk reduction strategies need to take place as early as possible. And that's particularly important if an individual is an APOE4 carrier. And then what another thing that this paper adds is that modifiable risk factors, or at least the set of modifiable risk factors studied here, might be related to progression in only in amyloid negative individuals. And this may be driven by an association with BMI and episodic memory decline. One thing this suggests is that the potential protective effect of modifiable risk factors may actually be diminished when you reach a stage of preclinical Alzheimer's, so in the presence of abnormal amyloid burden.
Fantastic. Thank you so much for walking us through that, Rory. That was really, really helpful. And I think it's really helpful as well to think about how the CADE is put together. A lot of these composite scores have their own sort of unique and nuanced components to them. So, and we'll drill down into some of those in a second. One thing I think would be worth mentioning that you and I had sort of discussed offline on Twitter, in fact, was that that there was a recent publication came out, and we can post this up in our on our Twitter feeds, but that obesity is now considered to be the top modifiable dementia risk factor in the US, at least in the United States. And this has come out from recent CDC data based on the US Behavioral Risk Factor Surveillance System, the BRFSS. It's a massive census questionnaire that's given out. In this case, it was about 350,000 adults from across the United States. So I think, it probably is not entirely surprising that the BMI would have an impact. And there's also some really cool data that's come out from Dr. Jenny Rabin's team, and a few others that are slipping my mind at the moment, but suggesting that higher BMI, even just at the baseline, so these are individuals who are about 70, is having an impact on changes in cognition over time, and potentially on changes in amyloid accumulation as well, in other data sets. So these are independent cohorts from the Australian ABLE study. So pretty cool how this is all sort of coming together in some ways. One thing I wanted to touch on first in terms of questions was, what do you think the strengths of the paper were to you?
Yeah, so I mean, well, aside from being a very well written paper and it was an
Yeah,
enjoyable read,
I agree.
yeah, it was an incredible data set. So a really large sample for a longitudinal study,
Yeah,
592 older adults. They had really long test retest intervals. So there was an 18-month gap between their follow-ups. So, that's over time, over their time period, that's enough time to actually see change.
yeah,
Often with longitudinal studies, in smaller studies, the time points can be quite close together, so it can be hard to detect cognitive decline or even hippocampal atrophy. And in this study, as well as the long test retest intervals, it was carried out over, I think there was a mean follow-up time of like 10 years, over 10 years anyway.
yeah.
So really a really fantastic data set. And on top of that, the data can't be accessed by other researchers. So we are able to go dig into it and try and pull out these associations ourselves or look at different research questions.
Absolutely.
So that
Absolutely.
leaves huge potential for further exploration with similar questions or related questions. So they were the strengths that I seen. But yeah, I really enjoyed reading it as well. So.
Yeah, no, I agree. The ABLE study is an incredibly valuable resource, and you're absolutely right. They have a huge amount of follow-up data, and you're absolutely right. You can get public access via the Loney website. And if anybody's curious, feel free to reach out to us on Twitter and we can direct you. There's also ways to collaborate with the ABLE team directly to have more access to data as well. But they're really a fantastic resource. And I think some of the strengths as well are actually leading on to some of the next steps too, because I think, and I know I'm jumping a little bit ahead, so sorry about that, but I do love thinking about what would be the next thing they'd want to be testing. And some of this is to look at how CADE and the CADE-MR are associating with, say, tau markers and amyloid accumulation. And I know that the authors mentioned that in their paper, looking specifically more at this sort of changing pathological cascade. And the fact is that ABLE has some of the longest amyloid follow-up out there, and in lots of different traces too, which is really fascinating. But I think that's a real strength of this study, is that they can, look at this sort of hippocampal atrophy and episodic memory decline as the first instance, and then take that next step as well within the same cohort, which is really cool. So in terms of limitations, I had a couple. I might lead on that first, and then I'd love to ask you, Rory. So for me, one of the it's not a limitation more than, and this is something that the authors also touched upon, more so just a point of clarification or a point for people to remember, which is that the ABLE study is very European ancestry dominated. Most of the individuals are Caucasian, European ancestry. And so it is actually a little bit more difficult to tease apart what might be the ethnic and racial differences across different groups and what impact that might have. Why that's important to me is because the crux of this paper is that it's trying to sort of extricate or pull apart what might be the modifiable risk factor impacts, as in explained variants for future brain atrophy and future cognitive decline. What might be the impact of modifiable risk factors to inform that versus what we already know as non-modifiable, very strong risk factors for Alzheimer's disease pathology, which is, age, E4, and sex to an extent as well. And the issue there is that different populations, if you have an Asian ancestry or an African ancestry, you have a different level of risk if you hold an E4 allele, for instance. So there's much lower risk if you have Asian background. And there really isn't the opportunity in the ABLE data set to be able to really tackle that with a lot of confidence. The power, the statistical power really isn't there to tackle those questions. And so, and we also know that lifestyle factors and modifiable risk factors are different across these groups as well. And you can think also in terms of ethnicity. So there's differences in Hispanic groups, communities, versus the those with European ancestry. So it's really important to sort of think about this within the context of generalizability, and I wouldn't say that that's something to hold against this study in particular. It's just to say this is an observation from a particular group, and it would be really interesting to see how this sort of plays out. This CADE versus the modified CADE plays out in these other groups. So that was sort of the main thing that I thought about in terms of the limitations. But yeah, would love to hear your thoughts too, Rory.
Yeah, I don't really. I didn't come across many limitations with the study itself. Maybe the one thing I would have noted was that the CADE score is heavily focused on cardio or cerebrovascular factors. But in the study here, participants with cardiovascular disease or cerebrovascular disease were excluded. We're looking at a sample, I suppose there's quite a bit of range restriction there, as everyone should be relatively healthy in relation to these factors. So we don't get a great range of people who would have higher risk based on the CADE.
Yeah.
And then aside from that, it's not so much with the study, but with the actual CADE risk score itself. It might need to be. Could be future research into maybe updating it or including a wider set of factors. So, it talks about modifiable risk factors, but there's very few. There's physical activity and education, and then sort of physical health factors. But even education is measured by years of education. Jen Manley has really great work, and others showing that years of education doesn't really reflect the benefits of education. In some cohorts, measures of reading test scores or vocabulary knowledge or verbal intelligence can better reflect the outcomes of education. So and in some cohorts that's more closely related to cognitive decline than years of education. So could maybe a different measure could be introduced rather than years of education, and that could be as easily obtained. Also, there's other important risk factors like smoking that aren't included, and there's no consideration of social determinants of health or socioeconomic status, which we all know can affect general health and dementia risk via various different systemic and structural factors or inequalities. So there's my interests are in cognitive resilience, and there's huge there's many different factors that could be incorporated there as well, but that's for a different study. They're not related to the study at hand.
I think it's still really valuable. What you're saying is at a broader level, what are we really thinking about when we're trying to classify someone's level of modifiable risk? And this is a somewhat limited scope. And I agree there needs to be some cap on it, because making something too broad, throwing the kitchen sink at it, then does make it really hard to then ascertain what part of that score is actually having an impact. And then the other thing as well is you've got to make these somewhat feasible to the extent that somebody coming into a clinic, if they did want to administer the CADE, they should be able to, relatively easily gather these data and make some inferences about that. But I absolutely agree that I think thinking about these scores and what's going into them and what is the implication of using different components in a composite score is a really important thing. The other parts, and we were talking about this offline before, but I thought that you made a really, really good point. And something we noticed was that in the CADE, there are some interesting points of scoring that was still sort of unclear to us. For instance, we in the literature know that there's a clear higher prevalence for women to be diagnosed with dementia in the population versus men. That's prevalence. Incidence is slightly less clear, but there is by a nose hair, women are more likely to show higher incidence rates, and they definitely show higher vulnerability to, at the very least, tauopathy. And yet in the CADE, the higher risk is imparted towards men. Now that makes sense, I would imagine if we're thinking about cerebrovascular disease and other sort of cardiovascular risk components, men are more likely to express greater cardiovascular risk, although that should also be sort of query or given a little asterisk, because women do also show very high cardiovascular risk prevalence post-menopause, just expressed in a different way, and much more likely to show sort of small vessel disease impacts. But that was a very interesting thing to me, because if this CADE score is a risk for future progression to dementia, and they're increasing the men in the risk there, that was very curious to me. And then the other components were things like how they were calculating the age band. If this is a midlife cardiovascular, midlife CADE score. The one thing that wasn't entirely clear to me in this paper was whether these CADE data were actually gathered in the midlife or whether it was based on baseline. And I think you're right, Rory, it was based on the baseline, which means that the age band maxed out, which means you end up with these odd ceiling effects in some ways. So there's some small things about how we might want to interpret and score these components, which I think are important to consider, at least when you're thinking about these
Yeah, I think, and even in terms of the scoring as well, I'm just looking there, education is it assigns a maximum score for between 0 and 6 years of education.
Yeah.
Or a medium score between 7 and 9, and then basically no risk if you have 10 years or more of education.
Right. It presumes a lot, I would imagine, because
in many contexts, 10 years of education might be considered low education or lower amount of attainment. So there could be further room for, splitting that up further and maybe, going above 10. But yeah, just there's a couple of interesting things there. So yeah, definitely there is there's a gap there maybe for, exploring the CADE itself further and maybe modifying it.
Yeah, it's a really interesting idea.
And I assumed as well, that the CADE was measured at baseline. And then, so one thing that I think we discussed this as well, but one thing that stood out to me a little bit, just we're talking about modifiable risk factors. So it would be interesting to see if changes in these risk factors themselves are associated with cognitive decline or hippocampal volume change rather than, baseline. Because then you have a little bit, maybe more stronger evidence to say that targeting these factors, such as BMI, would be a plausible strategy.
Yeah. Yeah, it's a really great point. I often struggle with the idea of talking about modifiable when we're just referring to a static risk. Like, do you have this particular thing? We actually don't know. If we capture it just at the one point, or depending on how the questionnaire is set up, whether it says, have you had this your whole life, or whether have you had this for the last year or for the past month? I'm not actually sure of the time frame. But if they're asking you about retrospective, to what extent are you remembering that, and to what extent is that static? Has that been your entire life, or have you had recent changes? It makes it sort of difficult to pin down exactly whether that modifiable risk has in fact been modified ever, or is it going to be modified? And I guess that we get to the bottom of these things using the clinical trial. So one example of a randomized clinical trial that's ongoing is the finger trial, as well as Pointer, which is the US example, where you're using a non-pharmacological intervention of lifestyle intervention essentially, but also some cognitive components as well, to try to determine how much the change of these risk factors, the actual modification, is having an impact on changes in cognition, atrophy, tau and amyloid themselves as well. But within an observational study too, which is what you're touching on, Rory, I think there's a lot to be said for how much do these things tend to fluctuate. We would imagine that across the life course, they fluctuate a lot. And that even in the midlife, that will have a big impact on downstream occurrences, but in fact, things will change as you get older too. So your BMI when you're older will have differing implications depending on your cognitive status, for instance. So if you are a dementia patient, you are more likely to have a much lower BMI. So there is a U-shaped curve of protective versus risk. So a very low BMI and a very high BMI are not good things. You sort of want to be in that sweet spot. And that does really matter where along the life course you are as well, in some ways. So I think thinking about modifiable risk factors as a static component versus a changing component and an intervention component, they all have slightly different meanings, and when you're gathering them and what downstream implications they might have. Yeah. And then the other thing that we were sort of talking about the other day that I think is really interesting to think about as well is this sort of the context of these sort of social determinants of health, because what is the CADE score reflecting is the thing that I can't stop thinking about. You know, having these higher risk factors sometimes makes me a little cautious, in the sense that it puts the blame on the individual. Not to say that that is in fact the case, but having a higher CADE score is not just reflective of someone's just individual choices, but also the structures that they have around them and the access that they may have to basically education, good social welfare programs, access to good quality healthcare, all of these things, and across the world, have a really big impact and will have a big impact on something like the CADE. And it shouldn't just be on the individual with their clinician trying to work this out and modify themselves. One really great clinical trial that just started in Australia by these authors, in fact, it's called the Better Brains trial. And the idea of it is somewhat individual focused, but it's trying as best as possible to take into account these sort of outside factors and using them to aid the individual to be able to modify their own risk factors. So the Better Brains trial works on trying to impact mood and sleep and cognition or cognitive engagement, and a whole range of different, and also physical activity. And the individual can choose which sort of areas that they would like to improve upon. And through that, they can access social programs, get in touch with different groups that they might want to get involved with. And this is all helped and supported by a clinician who will be constantly, or a coach who will be in touch with them fairly consistently. And I think that these sorts of ideas, so trying to figure out whether something like this is implementable at a community level, whether it's feasible to be rolled out, and whether it's adhered to. I think these sorts of programs are really fascinating. But I don't know, Rory, if you've had any thoughts on this yourself.
Well, that sounds fascinating. And just, I suppose, in terms of the social determinants of health, some of the factors here, like you need to have access to healthcare to understand to know your levels of hypertension, your cholesterol levels. You can't really typically find them out without being able to visit a doctor or a PCP, and wherever you may be. So, and if you know your levels, you can work on them. You can maybe try and reduce them where possible. But for a large cohort of populations in some countries, people won't know their levels. They won't be able to take action. So that's another sort of factor when you're looking at social determinants of health, and that, I suppose, also means basing a risk score on factors like these might reduce its generalizability as well across different relations.
Great point. And I guess that sort of leads us on to what's the implication for clinicians. There is definitely that, and this is always going to be the case, but being able to make sure that people are having their annual physicals, making sure that individuals are aware of their status in terms of these risk factors. It is hard if people don't want to go, and there's always those initiatives in various different countries. I'm from Australia, and I know that they have these initiatives to try to encourage people to continue doing regular follow-ups and annual checkups to ensure that we are catching things as early as possible, particularly these vascular risk risk factors because they have downstream effects on many different components, not just Alzheimer's disease. And but I think in terms of this particular paper, would you agree, Rory? I think one of the things that sort of struck me about this paper, or my immediate thought, was being a bit disheartened, because I had thought, oh gosh, when you modify that CADE, when you take out age and APOE4, there's nothing really, the modifiable risk factors aren't telling us anything beyond knowing if you've already got amyloid, that's it. You know, the modifiable risk factor isn't really telling us more about your risk. But actually, the more I've thought about it, I think actually the opposite now. I think that, in fact, the modifiable risk factor, where we're really going to get the bang for our buck, and again, as you said, we sort of already know this, but it's good to see this specifically laid out, is in those individuals who do not yet have high amyloid. That's assuming they will get high amyloid, but there will be, within that group of people who have low amyloid in this study, there are people that are probably on their way. Certainly the younger group who will be moving on to potentially accumulating amyloid. It's that low amyloid group, particularly those who are on the threshold and potentially accumulating, and we haven't isolated that. This is just a static measure of amyloid. Those people are showing decline if they have higher levels of these modifiable risk factors. And it's not just going to be the AD pathway. There's going to be a lot of other reasons for why this cognitive decline is occurring. And this is the group that we might want to be trying to intervene with, and maybe being able to do something really positive about their status downstream.
Yeah, I definitely agree. I think sort of the authors were sort of driving home the point as well. Like you just said, that again, as often is the case in many sort of risk reduction papers, that risk reduction strategies need to take place early. But yeah, I think just with that as well, though, it's worth keeping in mind that this was an older, the age of this cohort was older than the cohort used, or that the CADE was developed on. So there could be a gap there as well. Maybe if we study these individuals at an earlier time point, before baseline -1, before they were a mean age of 70, maybe we might get slightly different information. But I think it's still the key point remains that we need to intervene early. And yeah, if we can intervene even in healthy aging and people without abnormal amyloid burdens, we can maybe help there as well and reduce their future risk.
What would be kind of a cool idea, and it just popped into my head, so it could be really far-fetched, but so ABLE's been a part of some of these initiatives, and I know there's other papers out there that have been able to calculate an amyloid chronicity. So the number of years you've been, so how long do you have to hit a threshold of abnormality of amyloid? And you can sort of gain someone's level of amyloid time along a continuum, because amyloid accumulation is so regular across people. And what would be kind of interesting is to know what CADE score different people are at given their level of amyloid chronicity. The idea being that, those people who are on that trajectory and maybe are 10 years out or 5 years out from hitting a threshold, trying to ascertain those people who have this higher CADE score, and sort of trying to intervene with those individuals, trying to use this idea of where we think people are going, and in terms of their amyloid accumulation, and trying to sort of hit at this very early stage idea, which would be kind of interesting.
Yeah, that'd be, and I think that'd be really interesting. I think, do ABLE have longitudinal amyloid data as well? So
a lot. They have 3 or 4 time points on many clinically normal older adults. So it'd be really fascinating. And I'm pretty sure, I'd have to double check, but I'm pretty sure Dr. Toby Bethauser has been calculating an amyloid chronicity score. We'll have to contact him and find out more. but I think that'd be pretty neat. And so that's one next step. But any other next steps you can think of, Rory, that'd be kind of interesting?
I suppose it'd be fascinating to see it with the amyloid chronicity score, but even just seeing how the CADE scores relate to future amyloid accumulation.
Oh yeah.
We're interested in the downstream effect, or what we assume are the downstream effects of amyloid accumulation, like hippocampal atrophy and
yeah. Well, you know what I'd love to see? So they've got in that figure 1, they've got the CADE MR, they've got the episodic memory slope on the y-axis. But what I'd actually like to swap over is the episodic memory slope, the amyloid slope, and different levels of the CADE MR or the CADE as well, and just to see how much that is changing the slope of correlation. Because I guess the thing I'm really fascinated by now is these amyloid negatives who are showing this association between the CADE MR and their memory decline. Are these people under the hood actually are these people who are driving this? Are they on the threshold of that amyloid cutoff and are actually showing accumulation? Or is this an entirely amyloid negative, like independent process that is having some other kind of driver? So I have a feeling there may be still some AD related processes. The other thing obviously is tau that we haven't touched upon. There could also be other things involved with this. So TDP43, for instance, Lewy bodies, infarcts, all sorts of different cerebrovascular things. I mean, they've got so many things that they can look at now for next steps, which is exciting. And I'm really curious to see where they head with it.
Yeah, definitely. And I think, there's various different branches they could go down to further expand on this work. So like you said, looking at how these decade score relates to tau accumulation, or even just plugging tau in place of amyloid in this paper and seeing what the story is there. And I think something we might touch on earlier is like, do these findings generalize across different populations?
Yep.
If we want to really come out with clinical implications, we need to be sure that the usefulness of the CADE is generalizable. It isn't just specific to wealthy Caucasian populations. And then I think I might have mentioned this before, but is change on these modifiable risk factors related to changes in progression?
Yeah.
Important next step to really make a point about either a null effect or some effect for the usefulness of these risk factors in risk reduction for dementia.
Yeah, I agree. And one other thing, just touching on your interests as well. So you're interested in cognitive resilience, right? And so modifiable risk factors are an immediate associate with those sorts of things too, right? And flipping it on its head, the other thing that would be kind of interesting to sort of nail down a little bit more is, who are these people with the lower CADE MR and how are they performing if they have higher amyloid? There must be heterogeneity in those trajectories, both with cognitive decline and hippocampal atrophy. And is there some kind of interesting cognitive resilience residual that can be gained, including the CADE? I know that people more and more are starting to create cognitive resilience findings, including some kind of vascular risk score, not just AD pathology markers. So that'd be kind of interesting too.
That'd be really nice to look at.
Yeah.
We're tying it back to bouncing back at your interests. If you were to think of sex differences here, already there's maybe a discrepancy in how the CADE is scored for men versus women.
Yeah, removing sex entirely from the composite, and then I agree.
Yeah, that could be fascinating to see. Are these associations the same across the sexes? And that would have clinical implications, right? Because there's some modifiable risk factors that if we know BMIs may be important across both sexes, is that driven mainly by an association within men versus other factors maybe in females? Something like that would be interesting as well. Yeah. But I think we could. I
feel like we need to hit up these authors and see if we can do some projects. Well, thank you, Rory. It was such a pleasure talking through this paper with you. So just to encourage everybody to read through the paper, if you have any questions for us or any other thoughts, please do post it up on Twitter. Also, both Emily and Yen are on Twitter as well. And I would really encourage you all to ask any questions that you have about this particular study. And we're really looking forward to their next publications when they come out. Thank you so much again.
Thanks, Rachel. Thank you. Bye-bye.